Welcome back to the new session of the bladder tumor, part 21. Neoadjuvant and adjuvant therapy with cystectomy. Neoadjuvant systemic chemotherapy with a cisplatin-based regimen is recommended before cystectomy. Before randomized trial show that it achieved 5% absolute improvement in 5 years overall survival and 9% absolute improvement in 5 years free survival. Initiate neoadjuvant chemotherapy with 8 weeks of the cancer diagnosis. After neoadjuvant chemotherapy, perform radical cystectomy as soon as possible. Ideally, this will be after 8 to 12 weeks after finishing the chemotherapy. If the patient is not eligible for cisplatin-based chemotherapy, proceed directly to the radical cystectomy. Do not administer carboplatin-based regimen instead. Neoadjuvant radiation is not recommended. If neoadjuvant systemic chemotherapy is not given, consider administering the adjuvant chemotherapy when surgical pathology show extravesical extension, stage BT3, lymphovascular invasion, or lymph nodes metastasis. So if this is available, you can consider for them administering adjuvant chemotherapy when this surgical pathology have BT3 or lymphovascular invasion or lymph node metastasis. Also, non-randomized studies show that adjuvant chemotherapy lower recurrence rate and improve overall survival, and neoadjuvant chemotherapy is preferred based on the higher quality of evidence. Radical cystectomy without chemotherapy can be utilized for patients not eligible for cisplatin-based chemotherapy. The preferred chemotherapy regimens for either neoadjuvant or adjuvant therapy is either DD-MAX, that dose-dense methotrexate, vinblastine, and adrimycin and cisplatin, or GC, that's gemcitabine and cisplatin. Substituting carboplatin for cisplatin in this setting is not recommended because it reduces response rates and survival. A post-operative pelvic radiation patient with extravesical extension that is stage BT3 have high risk of pelvic recurrence and lower overall survival, even when the preoperative chemotherapy is added to the radical cystectomy. There is a paucity of the data regarding the use of post-operative radiation in this patient, but some data suggest that it may be decrease the local recurrence and improve disease-free survival. So NCCN 2021 guidelines states that there are no conclusive data demonstrating improvement in overall survival. It's reasonable to consider adjuvant radiation in patients with BT3, BT4 in 0 and 1 and 2, urethral cancer, bladder cancer following radical cystectomy. Pelvic radiation may also be considered if the patient has positive surgical margin. Post-cystectomy pelvic radiation is typically restricted to the patient with conduit urinary diversion. A new bladder or cauterizable conduit diversion will likely suffer too much radiation damage to make radiation a visible option. Partial cystectomy. The partial cystectomy for urothelial bladder cancer. Partial cystectomy is an attractive option because it preserves the bladder maintenance, and maintain patency. However, it may be associated with higher risk of all, causing mortality than radical cystectomy or trimodality therapy. Therefore, partial cystectomy is usually restricted to the patients who are unwilling to undergo radical cystectomy or trimodality. The criteria for partial cystectomy and pelvic lymphadenectomy: if the tumor is solitary, if the tumor does no CIS, negative biopsy, no period tumors, no invasions, and maintain adequate capacity, achieve negative margin. All this come with criteria for partial cystectomy and pelvic lymph node adenectomy. May be performed for primary bladder cancer if all of the above are met. No one of all this is available in the patient, or the patient have all these criteria: solitary, no CIS, negative biopsy, no period tumors, no invasion, maintain adequate capacity, and achieve a negative margin. Partial cystectomy and pelvic lymphadenectomy may be performed for primary bladder cancer if all of the following criteria are met. Solitary cancer, that is the solitary cancer that is stage T1 or higher for stage T1. Partial cystectomy is often reserved for higher grade tumors. Low grade tumors are usually treated with TURBT and intravesical therapy. No CIS, negative random bladder biopsy, no prior history of bladder tumors, no prostate invasion, ability to maintain adequate bladder capacity after resection. So we summarize it above, and here this is in details. Ability to achieve negative margin, also tumors that the bladder dome or in the diverticulum are good candidates. So the patient have ability to achieve negative margins tumors at the bladder dome or in the diverticulum are good candidates. Resection of urethral orifice with urethral reimplant may be performed when necessary. During partial cystectomy, bilateral and pelvic lymph node dissection should always be performed. Retrospective data show that the cancer-specific survival is similar for partial and radical cystectomy. However, partial cystectomy have as a higher all-causing mortality than radical cystectomy. A randomized prospective study comparing radical and partial cystectomy has not been performed. Older study report that the rate up to 18% of the tumor implantation along the incision or suprapubic tube tract is 18%. Okay, so with the current surgical technique, the tumor recurrence in incision or suprapubic tract is rare, but the older studies are show that 18% have the tumor recurrence in the incision or suprapubic tract. Some surgery recommend leaving only a urethral tract, urethral catheter, post-operatively to avoid tumor implantation along suprapubic tract, suprapubic tube tract. Recurrence in bladder occur in approximately 32% of the patient. Nearly two-thirds of this recurrence are non-muscle invasive. Non-muscle invasive recurrence can be treated in the same fashion as non-muscle invasive cancer that is found at the initial. Diagnosis intravesical, that's initial diagnosis, intravesical therapy. So radical cystectomy is recommended for muscle invasive recurrence. 15% of the patients who have undergone partial cystectomy will eventually require radical cystectomy. 5 year survival, 5 years cancer specific survival rates for overall stage is approximately 68%. This is for overall stage. Systemic chemotherapy, neoadjuvant or adjuvant chemotherapy with partial cystectomy has not been well studied. However, it with partial cystectomy is extrapolated for radical cystectomy data. Therefore, neoadjuvant systemic chemotherapy is recommended before partial cystectomy. Consider adjuvant chemotherapy when the neoadjuvant chemotherapy was not given, especially for patients with regional node metastasis. Partial cystectomy with chemotherapy can be utilized for patients not eligible for cisplatin-based chemotherapy. Partial cystectomy for non-urothelial bladder cancer. Partial cystectomy is usually treatment of choice for bladder pheochromocytoma. Partial cystectomy may be used for urethral adenocarcinoma and non-urological cancers that invade the bladder by local extension. TURBT with chemoradiation, or known as trimodality therapy. Trimodality therapy is used for urothelial carcinoma of the bladder, not for pure non-urothelial carcinoma. It used only for urothelial carcinoma of the bladder, is known as trimodality. The TURBT with chemoradiation is often called trimodality therapy because it consists of 3 modes of the treatment: maximal TURBT, chemotherapy, external beam radiation. Maximal TURBT remove as much as of the tumor as possible, then the external beam radiation is administered concomitantly with systemic radiosensitizing chemotherapy. Radiosensitizing chemotherapy is directly cytotoxic to the cancer cell, but it also causes cancer cell to be more susceptible to radiation, resulting in greater cell kill than chemotherapy or radiation alone. For trimodality therapy, commonly used reduce sensitizing chemotherapy regimens which are administered systemically, not intravasically, include gemcitabine, 5-fluorouracil plus mitomycin, cisplatin-based chemotherapy, cisplatin alone, or cisplatin plus 5-fluorouracil, or cisplatin plus paclitaxel. Paclitaxel, this is known as cisplatin-based regimens. Okay, it might be alone or with 5-fluorouracil or cisplatin plus paclitaxel. This is considered as one of the radiosensitizing chemotherapy regimen. Okay, so which are administered systemically, not intravasically. This must be systemically, like gemcitabine, 5-fluorouracil plus mitomycin, and cisplatin-based regimens that with cisplatin alone, cisplatin plus 5-fluorouracil, cisplatin plus paclitaxel. Trimodality therapy is less effective for cancers that have any of the following characteristics. URBT did not resect all gross visible tumor. Stage T3, T4, multifocal CIS, extensive CIS, or hydronephrosis caused by cancer. Patients with any of these characteristics have a low cure rates and substantial risk of needing salvage cystectomy. Patients with small bladder capacity are also poor candidates for this approach because the bladder may shrink after radiation. The ideal candidate would have all of the following characteristics. The bladder tumor does not cause hydronephrosis, absence of multifocal or extensive CIS, a small and solitary bladder tumor, stage T2, no regional or distant metastasis that in 0M0, ample bladder capacity before treatment, and good bladder function before the treatment. This is the ideal candidate who actually have all of the following characteristics. Therefore, for trimodality management, the bladder tumor does not cause hydronephrosis, absence of the multifocal or extensive CIS, and also a small or solitary bladder tumor, stage T2, no real lymph node or distant metastasis in 0M0, ample bladder capacity before the treatments, and also good bladder function before treatment. Before chemoradiation, perform maximal TURBT and assess for CIS. Maximal TURBT, the procedure removes the maximum possible amount of the grossly visible tumor that can be resected safely, ideally without perforating the bladder. Include resection of the previous tumor sites and resection of any new tumor sites. Maximal TURBT reduces the risk of persistent tumor and increase chance of complete response to chemoradiation. It may also disease-free survival. Assessment for CIS. Patients with multifocal or extensive CIS are not ideal candidates for trimodality therapy. To determine if CIS is present, biopsy area that appears suspicious for CIS using blue light or narrowband imaging can help identify this area, and obtain random biopsy of normal appearing mucosa. Bladder biopsy include prostatic biopsy if indicated. After maximal TURBT, external beam radiation is administered with concomitant systemic chemotherapy, which is actually systemic, not intravesical. Midway through the chemoradiation, perform cystoscopy, chest imaging, abdominal and pelvic imaging, CT or MRI. If persistent or recurrent non-metastatic carcinoma is found in the bladders, then cystectomy is recommended. If the metastatic urethral carcinoma is found, then administration systemic chemotherapy. If no tumor is found, complete response, the additional chemoradiation is delivered to complete the treatment course. This trimodality approach is more extensive than primary cystectomy and commit the patients to long treatment regimens. Recurrence in the bladder occur in approximately 43% of the patient. Nearly 2/3 of this recurrence are non-muscle invasive. Non-muscle invasive recurrence can be treated in the same fashion as non-muscle invasive cancers as found at the initial diagnosis, example intravesical therapy. Radical cystectomy recommended for muscle invasive recurrence after trimodality therapy. Approximately 25% of the patient who undergo trimodality therapy will eventually require cystectomy. So it's 25%. That's quarters of the patients, usually because of incomplete response to chemoradiation. Quarter of the patient, if we consider it as 100%. So 25% of the patients undergoing trimodality eventually require cystectomy. The delay in cystectomy compared to initial cystectomy may increase the risk of the disease progression. Also, this point is controversial. After incomplete response to chemoradiation, the patient may not be healthy enough to undergo cystectomy. Furthermore, cystectomy after radiation may have a higher complication rates and may limit the option for urinary diversion. In appropriately selected patients, trimodality therapy can achieve a similar cancer-specific survival and overall survival as radical cystectomy. This is a summary of initial treatment of bladder cancer. We have histological type of primary bladder cancer, and here we have usual initial treatment for non-metastatic disease. This is urothelial carcinoma, and this is non-urothelial carcinoma. Urothelial carcinoma usual type. The usual initial treatment is varies depending on the tumor state. Mixed histology, the treatment same as usual type, it varies according to the tumor state. Microbabillary or plasmacytoid or sarcomatoid variant, we will do radical cystectomy. Non-urothelial carcinoma, squamous cell carcinoma, radical cystectomy, but we can start by chemotherapy. So the radiation and systemic therapy are generally ineffective in the squamous cell carcinoma. So we will do radical cystectomy, sorry. Adenocarcinoma also will do radical cystectomy. And urachal carcinoma, in adenocarcinoma, the option for partial cystectomy. Urachal adenocarcinoma is also partial cystectomy or radical cystectomy. As you see here, that's radiation and systemic is not effective. Okay, the small cell carcinoma, the best management is systemic chemotherapy, that a patient who responds to chemotherapy, consolidation with radical cystectomy and or pelvic radiation may be administered. Pheochromocytoma, the partial cystectomy. So this is urothelial and this is non-urothelial. Urothelial we have usual type, mixed histology, microbabillary, plasmatoids, and sarcomatoid. All these variants we will do radical cystectomy, and all the usual type mixed histology we will manage according to the stage. Okay, thank you. This is the end of this session.